who will be joining us online to deliver the presentation. To do the introductions and chair the session, I call upon Dr. K.H.D. Milroy, Specialist Family Physician from Base Hospital, Dambadeniya, and Dr. Pradeep Gunawardena, Specialist Family Physician from District General Hospital, Gampaha, to come on stage.
Good afternoon, everybody. Now our next speaker is Professor Kumara Mendis. Professor Kumara Mendis is a distinguished specialist family physician who holds expertise in family medicine and medical informatics and has played a pioneer role in introducing electronic medical record system in divisional hospitals and university settings, making significant contribution to the field. As the Carter Chair Professor in Family Medicine and Associate Professor at Western Sydney University, he garnered recognition for his work in the field of family medicine and medical informatics. Professor Mendis stands as the first doctor in Sri Lanka with the postgraduate qualification in informatics. His interests also extend to evidence-based medicine and psychiatry. His publication records in peer-reviewed journals showcases his scholarly contribution in family medicine, evidence-based medicine, and medical informatics. Additionally, his role as the Assistant Secretary of Sri Lanka Medical Association highlights his commitment to medical advancement and professional development. Presently, Professor Mendis serves as a consultant family physician at the Department of Primary Care and Family Medicine, Faculty of Medicine, Sabaragama, University of Sri Lanka. Over to you, Professor Kumara Mendis.
Thank you very much for the kind words. Can you hear me clearly?
Yes, sir. Yes.
Yes, okay. And I hope that you can also see the screen. I have shared the screen. Can the presentation be seen? Right, okay, we'll start. I have to thank the college for giving me the opportunity to make this presentation, and it is our college that we are really proud of after so many years. Right, so the topic that I'll be speaking will be information and communication technologies in primary care. And so in this session, we will start with the few definitions of ICT and touch upon some of the basic essential ICT. There's a huge variety of information and communication technologies, but we will concentrate on 4 briefly: medical records, evidence-based medicine, continuous professional development, and telemedicine. And the last 10 minutes, we will touch on the current trend and the future of ICT, which is artificial intelligence in medicine. Okay. So, what do we mean by information and communication technologies? It is the internet, wireless networks, mobile phones, computers, software, video conferencing, social networking, and other digital technologies, enabling users to access, retrieve, store, transmit, and manipulate information in the digital form. It's a huge area. It covers almost everything. Information, but when we mean ICT, just 3 letters will cover a huge amount of things. And it is very clear the place of ICT, digital health, is just a part that is meant for us, healthcare. The WHO, World Health Organization, has this to say about the ICT, right? So the global strategy on digital health is to promote healthy, lives and well-being for everybody, everyone, everywhere, and all ages. So in 2020, WHO came out with the support of digital health, which is information technology used in healthcare. So you can see how much of importance for all ages, everybody, everywhere, and whether it's in Africa or America or the South Asian Pacific region, everywhere, right? So, sorry. Right. I hope you all know what is primary care. You all are primary care physicians, right? So the model of care that supports first contact, accessible, continuous, comprehensive, and coordinated person-focused care. This is supposed to optimize population health by reducing the disparities across the population by ensuring that all subgroups have equal access to services. This is one of the most important things that we must realize. Not only the Colombo-centric or big hospital-centric, the poorest of the poor who lives in a corner has to have equal access. This is the whole purpose of having a good ICT network. Right. Now we go on to, I just wanted to show this to show you how important is primary care. What a lot of work that we have to do, the primary care physicians take hold, ensure that, so this project, this piece of research was done in Gampaha district by one of your colleagues, Dr. Supunvitana and his team, with the handsome, very large grant given by the Ministry of Health. So you may have seen this diagram in Professor Nandani's textbook. We have been using the American diagram for ecology of healthcare. Now we have the Sri Lankan diagram. It is still to be published. I personally asked Supun for the permission to use this. Right. So if we take 1,000 population, in random population in Gampaha district, right, and follow them up for one whole month, nearly almost 93%, 938 people will have some kind of symptom, one or more symptoms during the 1 month. But only 45.2% will access healthcare. Where do they access healthcare? At a primary care area. This is the first contact care we are talking about. And only out of that 452, 23 will be admitted to a hospital and 9 out of that to a teaching hospital. Can you see the huge amount? And another important fact, out of this 452, 55%, that is more than half, will first visit a private practitioner paying a fee for service, although the government sector is free of charge. So this is hugely reliable data from our own country. So you can see the huge amount of work that primary care physicians has to do. And one of the main reasons we have to use all sources that are at our disposal, the infrastructure, manpower to deliver this primary care, and that is why ICT is very important to deliver this kind of primary care to a huge segment of our population. So we come to our first ICT important thing, the medical records, right? The foundation of delivering quality primary care is by having records. Without records, we just can't do anything, right? We had paper records. Then the unique feature, I think the world's first, the patient health exercise book, which we still use, and I think that still it's one of the most reliable sources. And then we got into medical records, and now it is not merely medical records, it's cloud-based electronic medical records. We'll just explain as we go along. The Ministry of Health came out with a huge, fantastic initiative. And by 2022 January, this is the information I got from the ministry websites, more than 80 hospitals had HHIMS systems with 25 million patients registered and 23 million of electronic medical records. It's a huge forward step taken by the ministry. I am sure that it has surpassed this number by now. Right. Then we just talk a little bit about the SLO EMR, which was designed by us at Kelaniya, and it is a cloud-based EMR. You may wonder what is a cloud-based EMR. Normally, EMRs used in almost all situations store their data in their own computer, in the hospital computer or your personal computer. But the cloud-based system does not do that. Cloud-based system, whatever you enter is entered in a secure server in another reliable place in the internet or the server in a Sri Lanka Telecom or Amazon Web Server or some university server. So it is very secure. You don't have to worry about, protecting your data, having the continuous power supply. No, nothing. You just enter the data, it will be secure, right? And the access is dependent strictly for doctors who have the authority to see the record. Is the other part. So this type of system, why do you think this type of cloud-based EMR is important? Just imagine if you put the exercise book that the patient carries into the internet by somehow. What happens? Every doctor who sees the book can enter the data. This is exactly what the cloud-based medical record system is. A patient, single patient has one medical record, and all doctors, authorized doctors, have the access of entering data into that single patient record. So you don't have multiple records, one for the OPD doctor, one for the GP, one for the consultant, no. It is all like writing in the exercise book that the patient carries, it is all on one system. And if we can have this kind of the open cloud-based system, it is the forward-looking step, which is all developed countries have now been used. So we can leapfrog from a developing country into a developed country using just this cloud-based record. And this system we design using open software, open source software, so the college can also do the same. So it is not, we did not design it from scratch. We designed, these are two open source software that I have indicated, right? So anybody can use this. So then we come on to the college's contribution. I firmly believe that the college can facilitate the use of electronic medical records in primary care. College has very good contacts with the Ministry of Health. They still have this, the electronic medical record that they devised and running. If we are lucky, our college can come to some agreement and get one of their electronic medical records, the HHIMS system, or we can design a system for the college and share it with the members, paying a nominal fee that the college spent in developing this, right? It is a future investment. Both the members and the college can gain a lot if we go this way. Now we come to the second part of the ICT, which is evidence-based medicine using the point of care resources. This is, if we want to provide quality patient care, we have to have the best evidence at our fingertips. Otherwise, we just can't, if we are to compete with other specialties, right? We have to have the best evidence now, at the time we see patients. And the best way is to subscribe. And the best out of the three, I am sure you have used one or more than that. for our use as primary care physicians having a small consultation time, the best is the BMJ best practice where the UK general practitioners use. It is a very, very fast system. You can log on and see the evidence in 1 or 2 sentences, and depending on the details, you can go down deeper. It is not as up to date, lots of reading. You don't have to do that with BMJ because it is designed for GPs, busy GPs. So my suggestion again is that if the college can get a license for the college, it will be very cheap than individual members trying to access, and college distributes this license to its members, right? That's continuous professional development. I think college has come a long way in using this. I have seen the lot of activities, CPD activities, that is the way prominent, the way to go. But just one more suggestion. So if you organize, the college organizes a CPD event, just after the CPD event, right, upload 3 to 5 MCQ type of questions, right, within say 1 hour or half an hour. The people who attended can answer these questions. It all automatically goes to a database and the CPD points are added. It is better than just logging and saying that, right, I listen to the particular lecture and you get the CPD points. So we had this system in Australia because all the GPs log on and then they are sent a small quiz, right? So that is one suggestion. Maybe the college can be the first college in Sri Lanka to adopt that kind of system, okay? And telemedicine, this is telemedicine, it's caring for the people at a distance. This is a very short form of definition of telemedicine. We are not using telemedicine. I thought that family medicine is a young discipline in Sri Lanka and has relatively few consultants with full board certification. But we have a huge primary care workforce of doctors in Sri Lanka. It will be very prudent to think having even limited telemedicine consultations with the PMCUs and divisional hospital staff, which does not have a consultant, which is the majority. If they have some clarifications, you allocate a time, say 1 hour, half an hour, they can just log on and have the discussion. Also, our family medicine consultants can, without referring patients, unless it is very important, have a discussion or telemedicine, teleconsult with a particular specialist and sort out the patient's problem if you want. So it is both. And also the exodus of doctors from Sri Lanka. Doctors are leaving our country. So at that point also, telemedicine will be, even a nurse in a peripheral medical care unit can ask for assistance by a consultant family physician. These are things that we have to just think about telemedicine, using telemedicine for the college and primary care. So now we have discussed the definitions, the 4 things that I think are important: medical records, evidence-based medicine, continuous professional development, and telemedicine. We come into the artificial intelligence in medicine. So the question, what is intelligence and can a machine think like a human being, right? So this question was asked when first the computers were invented in the early 1960s by computer scientists, right? The computer scientists thought that they could program how human beings think using programming languages. These were in the early 1960s. right? They said it is simple. We have done the computer and we can, they almost said in 1 or 2 summers, summer means they do a lot of programming in the summer, a lot of activities. So 1 or 2 summers, we can finish this programming of human intelligence, right? And just to make you understand what is intelligence, Alan Turing, a hugely important person in computers, defined this very small test, Turing test. Imagine there are 3 rooms. So you are inside one room, and these are soundproof. Nothing can be heard. Only the computers, there are 3 computers, 1 computer you have. In another room, you have a colleague with another computer. And in the 3rd room, we have a computer that is running an AI, artificial intelligence computer, right? So the communication is only by text messaging. Only you can, this was, you know, in 1960s, there were no images of Windows. So Turing said, this is the way to see whether a system has intelligence, right? So you asked a question, a simple question that you think is answerable by another human being, intelligent person, say, which has a degree or their colleague or A level, right? Right. You say, what is the capital of London? You type, right? And the same question goes to both. Your colleague answers, but you don't know which is the answer sent by the colleague or which is the answer sent by the computer, right? So you ask a couple of questions, 3 or 4, 5, and then if you cannot recognize which is the room that the computer is in, which is the room that your colleague is in, that means the machine in that room has intelligence. So this is a very simple test that was detected, a device in the 1960s, right, of human intelligence, right? So what is artificial intelligence? So artificial intelligence is a branch of computer science focused on creating intelligent machines capable of performing tasks that usually need human intelligence. This task encompasses a broad range of abilities, including understanding natural language, recognizing images, making predictions, and engaging in decision-making processes. So artificial intelligence in medicine uses the above-mentioned AI technologies in healthcare and medical research. Okay, it's a very simple definition of artificial intelligence. We have to understand 2 main branches of artificial intelligence. This is, I think, important at this point in time. We have 2 branches, the narrow AI and the strong AI. You will understand in a moment, in a few minutes, why I am telling this, right? 2 main branches. The narrow AI is designed to perform very specific tasks or solve very specific problems with a limited scope. Example, in medical language, medical healthcare jargon, a program, a narrow AI program can be trained to read CT scans or MRI scans of the lung or the brain, okay, and detect the CT, lung cancers. So we train one AI program, narrow AI program, to detect CT, read CT scans and of the lung and detect lung cancers, right? We have to train. I mean, you won't probably understand. The scientists have to put in CT scans, maybe 10,000 or 100,000, and label each of these with the defect of lung cancers and train what we call train the machine, the AI app to detect 10,000 or maybe more. These are all human diagnosed lung cancers of CT scans, right? Now, We put in a CT scan without labeling. We don't know whether it's lung cancer or not. Then the narrow AI program detects if there's lung cancer. But remember, this was trained only to detect CT scans of lung cancer. It cannot even detect a pneumonia. It may miss a pneumonia, remember. And the CT lung scan cannot detect a brain cancer. You can't feed in a brain CT or MRI. Can you see how specific the narrow AI is, right? Narrow AI is very, very specific. We'll just give you some example. There's a drug interaction checker, which is now highly specialized narrow AI application now. It is because it can be checked, right? And the other thing is artificial intelligence for breast cancer detection in screening. Now this is a Lancet study interpretation. Replacing one radiologist with the AI for independent reading of screening mammograms resulted in a 4% higher non-inferior cancer detection. It is even above. It detects because, remember, radiologists will feel tired. Radiologists may say, I can read only about 5 or 6 scans, but this will go on and on 24 hours a day without any problem. So narrow AI is very, very limited in certain fields, especially CT scans, brain images, skin problems, pathological diagnosis, that kind of very narrow thing, but only for that item, remember, right? And there's a very new term used by the American Medical Association. I thought that I should be sharing with you. It is called augmented intelligence. So augmented intelligence is, we use the AI, especially the narrow AI, in an assistive role, but we don't allow it to replace the human intelligence. I think that's the way to go. We use it as a tool to increase our detection rate of cancer or anything, but not replacing it. Final say is with the human being. Strong AI. Now, what is a strong AI? Strong AI is also known as artificial general intelligence. AI system that possesses human-like intelligence. These are human-like intelligence AI programs capable of understanding, learning, performing tasks across different domains. It is not restricted to strong AI. Eventually teaches itself to solve problems, new problems. You all know, I think the whole world knows about the two things that made headlines, ChatGPT and Google Bard. These are strong AI programs, right? There are two, if you have used these two, there are a little bit difference. There's a little difference between ChatGPT and Google Bard. ChatGPT has been programmed only up to 2022 January. It can't answer any questions after that, up to now, especially if you are using the 3.5, which is free. There's another version, I don't know what it has, ChatGPT 4. But Google Bard is the Google's way of presenting to you strong AI. It can undertake up to the minute answer questions about research or medicine or building a house or planning everything. A road that was newly built last month can probably be identified if it is on the map, right? So these are the two things that most of us associate when we talk about artificial intelligence, which is a strong AI, right? So why am I telling? danger, handle with care, the strong AI especially. If you just think, doctors normally will prescribe a new drug only after a randomized control trial has been on, one or more randomized control trials have been performed, and a certifying body like the FDA or the NICE have okayed it, and our local authorities have also okayed it. I'm not telling about immunoglobulins, right? Some things can bypass this and come, that is not my issue. Most of the drugs are coming through a randomized control trial through authorities to us, right? That is how we were trained. Now, exactly how strong GP works is not known, and there's a black box element. We don't know how it really works, right? And no medical body has tested or authorized strong AI application, unlike the narrow AI applications that has been thoroughly assessed, right? So people who have invited the large language models, which is the technical term for strong AI, warns us that this product at this point in time is not reliable, right? So this is why doctors should not use it for any kind of healthcare issues. Asking a diagnosis, asking anything, nothing. We should keep away from strong AI applications for healthcare use. Right. Now, this is the last thing. Last slide. What would be the ultimate aim of ICT in primary care? Right. There's a nice book, if you can see this, that this was written by Eric Topol. You all know Medscape. This is the founding author of Medscape. He's a cardiologist, a genetist, and a world-renowned expert in artificial intelligence and informatics. He wrote this book on deep medicine, which is all about how AI can influence healthcare. I'll give you 5 seconds, just think, what would be the ultimate aim of ICT, which includes AI, in primary care? Just think for 5 minutes, 5 seconds, right? You'll be surprised. This is what Eric Topol had to say. It should be to increase the time doctors talk to their patients, because artificial intelligence, informatics, everything will be taking care of your computer-based records, EBM, everything will be delivered to your doorstep in your tip of fingers. You have to establish the doctor-patient relationship that is fast dwindling. This is not what I say, this is what Eric Topol, which is not even he's not a family physician, because I think with all this technology, we tend to pay little or maybe decreasing time to establishing or at least talking to the patients, right? The doctor-patient relationship, right? The patients need doctors to listen to them, ask questions. They sometimes want you to do a physical examination, at least to touch them and see. So the patients are looking for the human touch and the relationship they are looking. We doctors need to provide the doctor-patient relationship that is all about family medicine. So hope you have, at least with all this ICT talk, remember all these will be important to you to deliver, but you have to do the most important thing a machine can't do. Build the doctor-patient relationship and carry on with the future. Thank you. Any questions, Prabhat, we can answer.
Thank you very much, Professor Mendis, for the words of wisdom on medical informatics and electronic medical records, which is very informative and thought-provoking, and which is the cry of the present day. Now the floor is open for the question.
Yeah, it's a question. Thank you very much, sir, for your very wonderful sort of presentation or the lecture. So I would like to ask this question. This is regarding narrow AI. According
Yes.
to my understanding, is it like it's good for screening process? For instance, as you mentioned, for the lung CAs or whatever, it's very specific. So I would like to know what is the specificity and sensitivity in this using this narrow AI, if you use it. Is there any idea about that?
Yeah, can somebody, I just didn't, I'm not sure whether I heard it correctly.
Sir, can I repeat the question? Can I repeat the question?
Yes, please.
This is regarding narrow AI.
Yes.
And if you use narrow AI, I think it is good for screening.
Yes.
And if you use it for screening, and what would be the specificity and sensitivity? So that's the thing, because if you use a screening tool, so there should be some, because if there are no human errors in that, so that's my question. So is it very specific or sensitivity is very high?
Yes. I think I heard, so that I can now, was it, who was speaking? I can't see you, anyone.
It's me, Lalanta.
Hello?
Hello, it's me, Lalanta.
Sorry?
I am Lalanta.
Yes, I just thought that it was you. You always ask questions, Anta. Thank you, at least. Right. Okay. Now, imagine, because the commercial applications are just about to come in, that you order a mammogram, right? And it has to go to a human physician, human radiologist, and it has to be reported. And instead of that, you have the AI app, which is, as a drug, was certified by certain, maybe American College of Radiologists, or I don't know whether they will even encourage that kind of thing, because the radiologists will have their practice curtailed. But then we scan the thing, that now also we get the digital scans of mammograms and CTs. We just send it to the AI program, it will detect. The cost is the first thing. Then the delay, right? It will be almost instantaneous, within minutes it will scan. And the patient, you can discuss about the patient's with the result, without a delay, without all the anxiety. You know how much of anxiety our patients go through when they do a breast scan and await the results. Is that what you asked, Dr. Lalanta?
So that's actually I asked about narrow AI, sir.
Yes, narrow AI.
And if can we use it as a screening method, because there's no human errors in that.
Yes.
And if you use it, so what's the sensitivity or the specificity? I think it's very specific tool to get the true negatives, is it?
Yeah, it is very specific. But the thing is, the commercial applications that use it, say, if you ask me, where can we get a AI for lung cancer screening? Yet, they are not available at the commercial level. But they are very specific. Very soon, they will be, because they have been tested as a drug, right? The Lanka study says they have been tested with human radiologists and found to be having a much correct rate of diagnosis.
Sir, here Malkanti. Can you
Yes.
hear me? Can you hear me, sir?
Yes.
Malkanti, I wanted to ask a question about the ChatGPT.
Yes.
So, have you experienced about using ChatGPT in medical care?
ChatGPT.
Yeah,
No, Malkanti, I won't.
ChatGPT.
I just go on and have fun, but I don't use ChatGPT for any kind of healthcare. No. Because it is only programmed up to, if I have a question, I would try, I mean, just try the Google Bard. But both, I mean, they warn you, if you just ask them, I have a few symptoms, you can enter, can you give me a diagnosis of whether you should go to a doctor? It will first warn you that I am not a doctor, I am not capable of this, and then only they will suggest, right? So for healthcare, I have not. I just go on and ask very non-health things, and you know what is the best route to go to thing or product. I mean, they have lots of, but again, sometimes they are completely wrong.
So regarding, the ChatGPT is useful for the, the research work and the proposal writing, question finding to a very good research question and all. So do you have that experience? Because our trainees, I want to, give some inspiration about that if you are having such experience.
Okay. Dr. Malkanti, if you have, I know that both of you have lots of connections with the ministry. Get our college electronic medical record. I mean, that will be very, very valuable for all our members. I think the time is catching up, I'm not sure.
Okay, so thank you very much. It's really informative. Thank you.
Thank you. Thank you for giving me the opportunity, all the college, and thank you, Dr. Malkanti and Dr. Lalanta, Dr. Shane, who struggled with me, and Dr. Prabhat. I wanted to do this because I have to be on call at the Sabarakamu because we have a few issues. Thank you very much, and hope we will see you tomorrow.
Thank you very much, sir, for your kind help us on the behalf of Sri Lanka College of Specialist Family Physician, and your token of appreciation will be received in due course.